Welcome everybody to the third and final IGHI Global Health Forum of this term. My name is Justine Alford and I'm the Communications Manager at the Institute of Global Health Innovation, the organisation which is hosting this event today. Before we get started, can I just ask everybody, apart from the speakers, if they could just make sure that their cameras and their microphones are turned off? That would be really, really helpful. Thank you very much. And just for anybody who you might be new to our Global Health Forums, I'll just start with giving you a bit of a brief overview of these events, which of course are normally run face-to-face, but we're pleased to be able to keep them running virtually. So the forum is our platform to bring together researchers and students and staff and the wider public as well, but also largely from Imperial, to highlight, discuss and disseminate findings on research and innovations on relevant and a range of relevant global health topics. We usually host these events monthly throughout term time, and they've been going for a number of years now. We will be live tweeting throughout this event, so we would love you to get involved as well. So if you don't follow us already, please do. Our Twitter handle is @Imperial_IGHI, and you can also use the hashtag IGHI Forum. So a bit about our event today. Our researchers at the Institute of Global Health Forum have been working on a huge number of innovative projects since COVID-19 began. And these are working to support policymakers and health systems and patients and people who are working on the front line. And some of these projects we're going to be talking about today, which is the final of our two-part series on responding to COVID-19 through innovation. So this is the opportunity for you to learn a bit more about some of the fantastic projects that we've got going at IGHI and also the people behind them. We have three speakers joined with us today who are going to tell us about their three very different projects, and we're very, very pleased to have them here today. There will be a dedicated Q&A at the end, so please save up some questions. We won't be asking questions in between the sessions, but if you do think of any questions while the speakers are talking, then please, of course, do pop them in the chat, but you can also raise your hand at the end. So I hope you're looking forward to an engaging discussion. And I have the pleasure of introducing our first speaker, who is Matt Harrison, and he is a Senior Design Associate at the Helix Centre. And his talk is on design for dementia during COVID-19. So over to you, Matt. I think we might have a distracted Matt.
Sorry, now I'm off mute, and now I'll try and share the right screen.
There we go.
There we go, it's hiding at the bottom. Okay, is that, can you see the right, does that look like the right screen now?
Yeah. Thank you.
Great. Well, thank you for having me here today. As Justine says, I'm Matt. I'm a designer within the Helix Centre and have been there for a good few years now. But nearly my full-time work now within Helix is as part of the UK Dementia Research Institute Centre for Care Research and Technology. Let me just push, there we go. And I'm going to tell you mostly about a project called Community Makers that came out of this as a response to COVID. But just to give a bit of context, explain what we do in the Care Research and Technology Centre. We're trying to develop technologies and a system that empower people living with dementia and their caregivers using an intelligent, connected home type approach with remote care monitoring. And as designers, we're working across this big centre with these different engineering and robotics and clinical streams within them across Imperial College and University of Surrey, and we're doing this sort of user-centered design for the whole centre, for the whole study. The experience like to be part of this connected home with all these sensors for people with dementia and their carers. So we work very closely with people in the community to shape the research and shape the course of the centre and make sure it's answering the problems that real people have out in the community. And just a quick schematic of what we're trying to achieve: a connected home with a remote monitoring clinical dashboard and a research interface. And what we're trying to do is detect infections early, prevent falls, identify and manage agitation within the home, learn more about sleep and behaviour with dementia in the community. Wow, part of this slide didn't show. Let me try again. Reload. Oh goodness. Okay, well I'll skip that slide. I can't remember what it was. Didn't show. I don't know what's going on there. So our job is designing. I remember now. It was showing the connected home includes things like Alexa devices, sensors, scales, and thermometers, novel devices, in-house radar, and in-ear EEG sensors and things like that to monitor vital signs and behaviour and symptoms in the house. And also as part of that, we're designing a clinical dashboard so that the researchers and doctors and clinicians know what's going on. And we're also designing a companion app so that people at home know what's happening to their data and stay involved. Now as we moved into COVID, our usual design practice is about getting to know people in the community, visiting their homes and getting to know their lives. And it's usually a face-to-face type of activity, or we hold workshops in our glass box at St Mary's. And of course, that stopped very promptly when COVID arrived. We were unable to meet people face-to-face anymore. Also, some really interesting things happened within the cohort of around 50 households that we were, looking after. There was a sudden increase in deaths, not directly related to COVID, but possibly to symptoms of isolation and the impacts of people having to change their lifestyles very quickly and abruptly. We moved our co-design activity online, and we started using Zoom and Teams to speak to the people that we're designing with and for, and it proved very effective. We were able to build a really good relationship with the people we're designing for by meeting them more regularly than we would have in real life. And we also found that people enjoyed it more. They liked, when they were isolated at home, they liked coming to meet us and talk about the project, and it became a bit of a sort of a community group in itself. And that led to this next project, which we've called Community Makers. And we wanted to see how we could help address this needs of isolation experienced by people with dementia in response to the pandemic. It started with, well, first of all, a little bit about the need, the impact of people with dementia. This is quite a recent report from Alzheimer's Society, but it illustrates what we saw happening. More than a quarter of those who've died of coronavirus in England and Wales have had dementia, making it the most common pre-existing condition for COVID deaths. The excess deaths were twice as much as previous years. A lot of deterioration in the symptoms of dementia experienced, and in a lot of the deaths, 40% or so, were also accounted for in care homes. It was a group of people that were very vulnerable to infection, to COVID, to the symptom, to the effects of COVID. But it's also a group of people, people with dementia and carers that rely really heavily on community in order to manage day to day. Normally, the carer is a partner who's also elderly, also got their own health conditions, and typically they rely on community groups, friends and family, neighbours coming to help out. Sorry about a couple of typos I've just spotted in the slide. Also, people with dementia struggle to adjust to different routines or understand the need for changes. It drives up agitation and difficult behaviours. It drives up tension. If carers can't sleep very well, then they lose their ability to continue to provide the care that they need to. And the alternative, the fallback for when care at home falls apart, is a care home, which during the COVID pandemic has been a very unattractive option. For reasons that we'll be familiar with. So the Alzheimer's Society put out a challenge relating to COVID on their innovation hub, and we contributed to it with an idea for an online community centre to address isolation, building on these ideas of using Zoom and other things to reach people. And this evolved as we then worked with the Alzheimer's Society Innovation Team and the University of Worcester And we came up with this idea of supporting community dementia groups to get online. So a lot of people already out there in the community with established groups, with established relationships, but they didn't have the technical or digital know-how to move from meeting in village halls or meeting in churches or meeting in people's homes to get online. So we wanted to create a space to help them make the shift to use technology during lockdown and afterwards, preparing for future local lockdowns. And also, this has exposed how isolated people are with dementia before COVID. There's a hope that after all of this, we can move into a hybrid model where we're using both physical meetings and digital interactions to reach more people and support more people. So we created an online through co-design processes with community groups. We created a toolkit online called communitymakers.co.uk with insights and guides on how to use software and devices within the home, how to get people connected, templates on different ideas of how to run activities and reach and engage people, checklists of things to consider when setting up an online resource. And we've also built a Slack network, Slack's like Teams or whatever. It's a place online where people within groups, we've got about 60 groups on there at the moment, can share ideas, share insights, help problem solve together, and communicate with each other. I was had on this morning, we have monthly forums where we invite community groups to come and give case studies and presentations of ideas and get feedback from the group. So it's a sort of community of community makers. And just some of the things that we have come up on, a couple of highlights from the group. What's come across is a need to think about the people who aren't connected, people who can't get online very much. There's a lot of ideas and templates around creating offline experiences but delivered through online means, if you see what I mean. So boxes of activities to send to people that keeps them connected, gives them something to talk about over the telephone, helps make sure they don't feel forgotten. Hugely important. This wonderful template of, not everyone can manage a Zoom call. People find it overwhelming, but this lady, Helen Hunter, would do tailor-made visits to local attractions by request to take people outside, to take them out into the world, and put them on YouTube for people to see and enjoy. So taking the ideas of of a Zoom meeting but making it more accessible. These are some of the groups that we've got involved, and where my time is running out very quickly. These are some of the groups who got involved, and they range from a couple of groups have been inspired to start via Community Makers. It's a digital first group, so growing, using just Zoom and digital connections into people's homes, to groups who are looking after over 150 people, from before the pandemic hit. And we've got a good range of urban, rural, around the country, a lot in Scotland and Wales, and some groups focused on ethnic minorities and the like as well. And we've just in the latest Alzheimer's magazine, Alzheimer's Society magazine, saying that it is, a testimonial here saying that the toolkit's given this Sherry the confidence to get online and give it a go and embrace digital, and really that's what we're trying to achieve and what we're all about. I'll call it a day there because my time's up, but I look forward to some questions a little bit later.
Thank you, Matt. That was a really great talk, and thank you so much for introducing us to Community Makers. It sounds like a really a brilliant initiative, and some fantastic efforts to make sure that really that nobody is left behind during COVID-19, which obviously must be quite challenging with such an increased reliance on technology at the moment. So thank you very much, and we have had a couple of discussion points popped up in the chat, so we'll get to those at the end. Thank you very much. So now we will move over to Dr. Ana Luisa Neves, who is an MD and a research fellow at our Imperial Patient Safety Translational Research Centre. And she is going to talk to us about the impact of COVID-19 on the adoption of digital technologies in primary care. So thank you, Anna, and I will pass over to you.
Thanks, Justine. So I'll try to share my screen. Let's see if it cooperates. Hope it will. Okay, so it seems, although we have tested it, it seems to be a bit grumpy now. Let me try again. Oh my God. Okay, so I'm not sure what's going on. So I might ask Nikita to open it if she doesn't mind, because it's definitely struggling. Sorry, Nikita. That's, even if we tested like 5 minutes ago, it's unbelievable how.
Get it working one way or another. I think Nikita's on it.
Yeah.
Let's go to desktop. Can you see it? I'm sorry.
Yep, no, that works.
Okay, perfect.
Is not that one, I think.
So sorry. Yeah.
Gonna coordinate my tab.
Is this, yeah, is that one, Nikita? Thank you.
Sorry.
Thank you so much, and sorry, apologies on behalf of my computer, which seems to be dying. So good afternoon, everyone. My name is Luisa. I work as a research fellow at the Patient Safety Translation Research Center, and most of our work is actually about digital technologies and how do we make them better tools to better serve patients. Actually, how do we make them more patient-centered, more effective, and more equitable as well? So if I can have next slide. So the promise of digital care was already there, honestly, before COVID. So for several years, we have heard that digital care was going to transform the way we deliver and we reach out to patients. But one of the main challenges was actually that the adoption rates remained very low. And next slide, please. So what we also know is that the promise was there, and there was also political willingness to make this work. So there were several plans in the NHS to actually transform primary care and make it more patient-centered and actually offer patients as an option at the very beginning of their journey, an option to engage with the digital channel to start to contact with healthcare. So as we'll see in the next slide, there were very defined objectives of the type of offer that we wanted to give to our patients. So by 2023-24, the NHS long-term plan actually already had this objective of offering digital first care to every patient. There was also a willingness to increase the number of online consultations and the opportunities for patients to book their appointments online. So this was planned and this was supposed to happen, but as we all know, this happened much earlier than actually was expected. So as we'll see in the next slide, our reality changed abruptly in the beginning of this year when COVID hit us, and all these plans that were basically part of an overall structure and the overall strategy were basically rushed in ways that we could not have anticipated before. So next slide, please. So I think the key message, and I think we have all experienced this one way or another, is that new ways of living and new ways of using healthcare and providing healthcare basically appeared from one day to another and basically were adopted in a way that we could not really anticipate before. So all these ideas of having a virtual life, working 100% remotely and actually delivering primary care almost 100% remotely was something that was not really conceivable for most of the people, but it actually happened overnight. So having conversations with most of our colleagues from primary care, we started to realize that this transformation was really having a big impact on the way they were working and also a big impact in the way that patients were being served. So that was the rationale for start exploring this area and trying to understand what was the impact of this remote care, how was it changing the experience of healthcare providers, and most importantly, how was it changing the experience of patients as well. So next slide, please. So the objective of this of our project was basically to try to understand how did COVID actually enhance the uptake of digital first models. And I'll just take a second here to explain. By digital first models, we are talking about every solution that actually includes a digital point of contact. That might be a telephone, which is digital, a smartphone, that might be a video, or eventually an online website that provides triage. So we had this hypothesis that actually COVID had enhanced the uptake of these digital first models, and we wanted to understand what were the perceptions of general practitioners on the impact of the care being provided to patients. And most importantly, we wanted to learn from this and try to understand, okay, now that we have the picture, what can we do with it? What can we learn, and how can we transform the system in the future? So as you'll see in the next slide, the project that we are running, so the data collection actually ran between June and September of this year, and the objective was to ask general practitioners these three questions. So how was the adoption? What is the impact in care? And how can we move forward? What can we learn from the future? Next slide, please. So just a brief word to say, I'm presenting this work, but it's certainly a work of a big team. So there are more than 20 institutions involved and more than 30 researchers all over the world. There's a lot of people at Imperial, at IGHI. We are also partnering with the Primary Care and Public Health Department at Imperial. And obviously, we also have partners in the 20 countries that where we surveyed general practitioners. So most of them were in Europe. We have established a collaboration with the European General Practice Research Network, but we also established partnerships in the United States, Canada, South America, and Australia. So the next slide will show our first results. So we've got more than 1,500 replies from GPs from all over 20 countries. As you can see here, we have a really well-balanced distribution. So we have people from different age groups and people from different genders, and also a balanced distribution from people in rural settings, urban settings, and mixed. So this was really important for us because we knew, since this was an online survey, we somehow were already biasing our sample because we couldn't really reach it out in a different way. But we wanted to make sure that our sample was as diverse as possible so that we would capture the full picture. So in the next slide, you'll see that most of these doctors actually have high digital maturity. So most of them were used to using the electronic health records in the past. Almost, well, more than 95% actually had access to that. Next slide, please. So this sample, apart from also at the high maturity and high experience with electronic health records, and in general, they were quite prone to using digital technologies. So most of their institutions actually had a very positive perception about the impact of using electronic health records and digital technologies in general. So they had experience, the organization was developed in that sense, they had individual abilities, so they were a sample that was quite willingness to use this technology, and this is something that we need to put in context when interpreting our results. So moving to the next step, we tried to ask them what was the availability of these technologies before and after COVID. And unsurprisingly, as you can see, there was a major increase in video consultations and telephone consultations. We were quite surprised by video consultations because we knew that actually a lot of countries didn't have a platform to properly implement those, but the increase was up to 60%. So we are quite curious now to understand how different countries did that, and we can discuss that. I think there are really interesting questions to make here about what type of platforms were used, which were the security standards, and what can be improved, because this is something that will continue in the future. So we really need to understand what needs to be fine-tuned in that aspect. We were also quite interested to understand if general practitioners actually had any kind of training or support, and this was a very good surprise because this was not really aligned with our perception, talking with general practitioners in the ground, but actually more than 60% of them said that they had overall good support in training, providing either telephone or video consultations. The less positive aspect was around guidance on cybersecurity, and again, there was no very clear guidance on that. And because it was an emergency situation, of course, a lot of people were actually using or recommended to use either FaceTime or WhatsApp or whatever technology patients were familiar with. And this, of course, has some implications that need to be discussed. So moving to our second objective, we wanted to understand what was the impact in the care that was delivered to patients. So I must reinforce here that we asked GPs about their perceptions about how care was delivered. And again, there's a second part of this work which will actually appraise patients' perceptions on this aspect as well. So it was really interesting to see in the next slide that most GPs actually had perceived a positive impact for most digital first solutions. So the rates, you can see the highest rates go up to 80%, 70%. So in general, they found that the solution was really valuable. Of course, we need to put this in context of the pandemic, and it's going to be important to understand how do they perceive this in the context of a non-pandemic situation, basically. So the next question that we asked was about the impact on different dimensions of patient care. So we wanted to understand where was the actual benefit, which were the areas in which these technologies actually improved care. And it was interesting to see that obviously they would say that the effect was very positive in whatever was related to COVID, let's say remote triage, let's say remote monitoring. A different aspect that was actually got very high scores was also around the management of non-COVID conditions. So we are talking about management of chronic patients with diabetes, hypertension, or even acute minor illnesses that could be managed remotely. The aspect that was not that positive, and actually the one that got lower positive or lower agreement rates, was around equity. So GPs were actually concerned that although being a positive tool, this kind of approach could actually entrench inequities that were already existing in the population that they serve. So going to our next point and final point, we wanted to understand what can we learn for the future. So this was a massive real-life experiment, exposed us to technology that we wouldn't have been exposed otherwise. So what can we learn for the future? Overall, the experience was really good. So most of the people, and it's over 70%, said that their experience was either good or very good. So we tried to understand what actually needs to be improved. Next slide, please. So there are main areas that need to be improved according to general practitioners. And this is also something that's not particularly surprising because we have been discussing this before COVID as well. And a lot of this is actually around partnering with healthcare professionals and with patients to make sure that they are involved in these processes, that they know they are involved in the design and the implementation of the systems that are used, and of course that they are able to input their experience and to feedback their experience and their perceptions so that we can continuously improve these systems. There's also something really important about patient safety and security and data security. And obviously we understand this was an emergency situation, but we need to make sure that digital solutions adopted in the future actually comply with most of the standards, that are required. So moving forward, we know that this was an emergency phase. We understand that some of things have been speed up, and we know this has been the case in a lot of things in COVID. But we need to understand how do we move from this emergency phase and move into a transition phase when we understand what were the solutions that actually add value for which patients, in which circumstances, so that we can actually define frameworks to implement them in the future. And obviously, our hope is also that we could capitalize somehow on this speed and try to improve adoption in ways that could be more efficient than before COVID. So just to finalize, there's also a technology legacy and the policy legacy that we can take from all this experience. And obviously the system and the current situation has exposed a lot of weaknesses. So it's important that policies actually identify these weaknesses and incorporate them in future recommendations. I'm talking about infrastructure problems. I'm talking about problems with lack of staff, with lack of interoperability. I'm also talking about the lack of communication between different stakeholders, being them healthcare professionals, policymakers, and also patients. So these are the aspects that we need to incorporate in the future so that we can actually learn and use these learnings for improvement. Next slide, please. And I would like to finish this presentation actually with the same message that we had just discussed before, which is about the digital divide. We must not forget that although the solutions seem to be promising and hopefully we can take good lessons to implement in the future, we must not forget that while implementing these solutions, we must not leave specific groups of people behind. So while implementing, we need to understand that different groups might have different literacy levels and digital literacy levels, and these groups of patients need to be supported so that we are not actually widening the digital divide and creating more inequities than we had in the beginning of the process. So I'll just finish by leaving this comment is our last piece on the importance of doing that, of incorporating the perspectives of different patients and incorporating the perspective of different stakeholders so that we actually develop digital first care that's inclusive for everyone. Thank you. And thank you, Nikita.
Yes, thank you, Nikita. Thank you very much, Anna, for that fantastic talk. Obviously a very relevant topic given the digital world, or as you pertinently put it, the massive real life experiment that we are now living in. And in particular, we're really looking forward to hearing from the patients' perspectives at the other side of your study as well. So yes, please do keep us in the loop with that. And just a reminder, I have seen a few questions popping up, but if you have any more questions, please do put them in the chat box so that we can have an engaging discussion afterwards. And now I'm very pleased to introduce our final speaker of the day, Dr. Lindsay Dewa, who is a research fellow, again, at our NIHR Imperial Patient Safety Translational Research Centre. And she is going to talk to us about youth mental health during COVID-19 lockdown, a co-produced mixed methods study. So thank you, Lindsay, and over to you.
Thank you, Justine. Can you see my screen okay?
Yes.
Okay, fantastic. So yeah, obviously it's been quite a tough time for everyone with all the other projects that have been discussed so far physically. But my project is looking specifically around mental health, and I'll be focusing particularly on the co-production elements of the study going forward. To start with, I just wanted to, for anyone who doesn't know what co-production is, just to give a very brief definition. So co-production is defined essentially as a working partnership that's equal, that's sharing responsibility and power between those people that the research is about and the researcher and also clinicians. And we split it between these 5 main principles of co-production. I'm not going to go into too much detail because I'm very aware of timing of this, but essentially there's 5, and it's about joint power, that everyone has an understanding, all of the perspectives and skills are acknowledged and we all feed into that. Everyone's making a contribution equally, we're respecting and valuing each other's knowledge and viewpoints, so everyone's got different hats and we're all bringing those to the table. We all benefit from each other, so I benefit from the young people, and they're learning new skills and experiences that they can take forward into their studies and their next steps in life. And we have a lot of dedication to building and maintaining that relationship, particularly from the start, which we did. I mean, this study was no different, but I do that with all my studies. That first part is really important. So why bother looking at youth mental health during the pandemic? Well, we already know before the pandemic that young people were particularly at risk of sort of deteriorating mental health, particularly before the age of 24. We know 75% of mental health difficulties start before this age. Before this age, it's quite a key developmental milestone for many. So, you know, school completion, starting relationships, starting university, and joining the sort of the labour market. And when the pandemic hit, all these things were actually really disrupted, and young people were particularly vulnerable to public health crisis as well. We know early on that young people's mental health was identified as a priority alongside other age groups, but particularly young mental health. And we know that the impact of the lockdown, particularly around isolation and loneliness, so already the literature was saying that this was a potential relationship that we need to look at. what we didn't really know was what young people thought about this, and what they wanted to prioritise. So we decided to sort of have more of a co-produced approach that was mixed methods. So a survey and interviews were used, and I'll now tell you about the aim of the study. So you'll see throughout my slides, I'm going to focus on the stages that young people with experience of mental health difficulties were involved in. And we started with opening up this question of actually, okay, how are we going to prioritise this area? What do the young people want to know about? So we, building on previous research, we identified as a team 11 potential research questions, and we put those out to the public. So we had just about 7 hours open to the public for young people to actually prioritise their research question of importance. And the top research question was this research aim. So to, yes, use a co-produced approach, but to look at how young people's mental health was at the start of lockdown and how it's going to change over time, and also how the young people are actually coping with these new changes and the pandemic. Our objectives were therefore to identify the baseline characteristics and how these changed over time, to examine the associations between mental health factors and coping strategies, and obviously other factors such as demographics and other clinical things, whether they had a previous mental health condition or not, their personality type, and whether they are optimistic or not. And also to then further go in depth, so more qualitatively, looking at the specific experiences during lockdown and their coping, the ways that they coped during lockdown as well. So this slide is a little bit complicated, so bear with me. But this was sort of a two-tiered, also linear approach, in that we started with the survey. This was co-designed together with the young people. All the information sheet and the consent form was all done together, informing that language. And that was advertised to the public. And then we basically what we call mixing, and we combine that survey responses to the qualitative aspect of the study, which is the interviews, and that informed the topic guide for the interviews. And then we use both of those information to actually produce our interpretation and our analysis combined. The survey itself was only available for 2 weeks, but then a same 2-week period was open every single month for the last 6 months, so around April time to October time. And then what we're calling COPI 2, which is now looking back over that 6-month period, and we've just finished, as of yesterday, some follow-up interviews about those changes over time as well. So just to say that the young people advised on everything and informed everything, including safeguarding and ethical considerations. So what did we actually find out? Well, 796 people took part in this study. And as I say, this was primarily from April, May this year. The mean age was around age 19, but there was a full range from 16 to 24-year-olds of age. Most were single and staying at home, and around a quarter did identify as non-white ethnicity, which actually is an overrepresentation of the national population. A fifth had a mental health diagnosis, which included depression or anxiety, and just under a third had self-harmed before lockdown, which is actually quite high, considering what was deemed to be normal before lockdown. Around a third had poor mental health, and around 10%, 11% had self-harmed during the lockdown period, particularly in those 2 months that I mentioned. And we did a logistic regression analysis to identify what factors were actually predicting or associated with poor mental health during that period. And as you can see from this this graph here, that Black and British ethnicity was actually one of the higher odds of having poor mental health. But actually, if you can see this big line, it's a large confidence interval, so we have to take this with caution. But the other factors are more sort of significant. So behavioural disengagement, a self-blaming coping strategy, substance misuse coping strategy. Sleep problems were associated, but not as strongly as the others. A lot of our work with the young people as research partners involved them conducting the interviews themselves online with 18 young people. And we trained them in a full day online to be able to actually do those interviews. And we went through a whole range of different codes and used some really innovative sort of methods to do that. I'm just going to take you through a few of these quotes now. So some of the main things that came out was these different coping strategies. So positive reappraisal was something I did quite a lot at the start, trying to find things that I couldn't do before so I could see the good side of everything. I feel like this is a good time for kind of re-examine myself and really trying to focus on what I want to accomplish about things. Some people had reached out to their mental health services, but actually, the response wasn't that well received. So there was a high demand, but there wasn't actually the service in place for them, which we did find in quite a few of the interviews that we did. This is our results of those interviews. So this was a big thematic map that we did with the young people as research partners, and we used various different technologies to complete this thematic map. So we use Jamboard and sort of have initial discussions. We use the Trello software to actually put all our codes in one place and everyone could access it at the same time. So everyone had ownership of that data of our team. And then we use Miro software. Again, everyone can access it and move things around and change wording and things to produce this thematic map here on the left-hand side. And we had 3 main themes. The pre-existing and developed helpful coping strategies were split between 3 main things. So being avoidant, so sleeping to avoid, some were doing that, sort of avoiding the media and the news around that time, or the flip side of being really active in the way they were coping. So distraction came through quite strongly, and maintaining a routine. And on the other side is that people had a pre-existing coping strategies. So these protective factors that we saw, they either completely used to being at home, or they were more introverted in their personality traits. So that was kind of what they were used to. They were quite happy with that, and that really helped them cope during this the lockdown period. And positive family factors really came through. So those socialization really was strong. In COPE 2, which is looking through the changes over time, we saw that people have been coping fairly well. They've been worrying not so much through the last 5 months, but around the time that the tier system came into play, we can see this slight rise both in worry and both in low mood. So we need to just be sort of considering sort of different ways to be able to support young people because of this, and sort of plan ahead. And I think I'm just very aware of time, actually. I think I'm possibly going over. So I'm just going to rush through this quite quickly. We've just finished interviews yesterday, as I said, that we are still seeing some anxieties and worry about the future, particularly with things changing all the time. The new lockdown that's now just ceased, but also the tier system, and particularly around university next year, whether the exams are going to happen. People are quite lonely, particularly because there's no social activities, university halls, of course, people locked down in those. So there's still a need for this peer support and mental health support in general for people, that we really need to sort of continue even now. And that was also the case in the first lockdown. In terms of the next steps, we're going to finish the quantitative analysis, and we're going to finish the co-produced qualitative analysis as well of those interviews that we've just done. And actually just to highlight the fact that we're going to be disseminating those results and wider next year. So there's just another date for your diary as well. That was really rushed through. I'm so sorry about that, but so much to say and then so little time. So thank you very much for listening.
Thank you, Lindsay. So sorry that we were so cruel that we only gave everybody 10 minutes to talk about all of their amazing work, but you've done such fantastic jobs condensing such a vast amount of activities into a tiny little window. So congratulations to you all, and thank you very much. So now we will go over to the Q&A session. I wanted to first pick up on a comment that Ganesh has put down, which really has been a common theme running through all of these presentations, which was about the digital divide. So I did wonder, your thoughts on the implications of this for inclusion and how might we address these. I know, Matt, that you had actually mentioned that you had seen some positive, impacts on your involvement, but it'd be good to also discuss, how this digital divide might have implications for certain groups, maybe vulnerable groups, and those who might not have access to technology.
Yeah, well, from my point of view, a few things to note. I mean, within our study trial, the DRI Centre, I guess one of the inclusion criteria for people involved in the study is that their house is connected to the Wi-Fi, because it's a connected house. So connected to the internet, because it's a sort of a connected house solution. But the digital divide has become the main subject of conversation within community makers, and the way that the different groups within the community wrestle with that issue. They can make contact with people who are comfortable to use Zoom. Typically, they use Zoom, or they find ways to reach people who are not connected. And a lot of the sort of knowledge sharing and exchange has been about different devices that might make that access possible via a 4G connection and a managed device, so that even in a house that was not previously connected, are there possibilities to reach people through technology, and sharing insights on devices and providers and funding to support that. So that's one solution to get more people online. And the other is to find analog, offline, physical ways to support people by going to their front door and having a chat with them, or giving them, or including them with a newsletter, or all of the physical things that are coordinated via a connected digital community. The other point I would add is that by reframing the way these communities work, they have been able to include people that were beginning to get excluded by their physical abilities to attend physical meetings. So people are able to connect from their own home, which has been useful for some people. There's been a new type of intimacy and connection, because people are coming from their homes and they learn more about each other. They bring things to the to the video camera to talk about and share and make new connections, experience new things. So the digital divide is front and center of everyone's mind, but there have been some positive outcomes and opportunities from this sort of reaction, this seismic change.
Well, it's good to hear that it's funding isn't the only answer. So it's good to hear some other approaches that you've been adopting, Matt. Anna, Lindsay, I don't suppose you wanted to add anything to this before we move on to some other questions.
I could just.
I think you've just turned yourself on mute, not off mute.
I'm struggling with technology today. So I just wanted to echo Matt's thoughts as well. And I think there's also another layer that we might want to consider is not just the digital divide that we are creating by implementing digital solutions or not, is also the fact that we are performing research in a digital setting. So we are doing online surveys, we are doing online focus groups, and that per se is also a kind of divide. So I think that's a personal challenge for me as a researcher, is how we make sure that we do listen, we do have the right channels to listen to people that are not able to engage with us using digital technologies. And I think Lindsay gave a really good example of her project, and I think there's a lot of opportunities for us there, really.
Thank you, Anna. And Lindsay?
Yeah, no, I just wanted to add as well to that what we did as part of our study, particularly with the research partners, were sort of offer out different options and sort of ask them to provide their preference on and it's happened with different projects as well, but whether it's WhatsApp, whether it's Slack, whether it's phone calls, whether it's regular emails, whether it's a once in a blue moon face-to-face at distance, I mean, all these things were considered, and the primary choice was having a WhatsApp group, and that really worked well for us. But just offering it back over to the young people is the first thing I'd always say in terms of doing that. And I think potentially also I'm quite lucky with my population. Young people are obviously very digital savvy, and actually that's proved to be a big plus point, I guess, with our research. So yeah, just to add to that.
Thank you. Ganesh, we have got, you know, I spot that you have asked a couple of questions. We can probably, you know, quickly go over to you if you're desperate to ask another one before we go to other people's questions. Thank you.
I was just going to say, it's really interesting to hear about the multiple responses that you've had to try and deal with this really complex issue and not just have a one-size-fits-all approach. I think that's really helpful, and all of you should be commended about that. I mean, I often think about my own kids. So for example, 2 days before lockdown, I went out and bought an excellent laptop for them. So between the house, we had several laptops, several phones, and we all could work, you know, over that peak period. But I'm really aware there's a whole bunch of people who can't do that, and maybe have one mobile phone between the family, and then you've got kids doing homework, adults having meetings, and it's usually the poorest in our society who have been impacted by COVID the most, who are the least able to access. So I just think it's fantastic, all the good work all of your team are doing.
Yeah, thank you very much, Ganesh, for highlighting that really important point, and you know, and also for showcasing that, you know, all of our people who are working really hard to ensure that their research is inclusive. So thank you very much for that comment. Camille, I also noticed that we had a couple from you. So maybe if we start with a very quick one, your first question, before we move on to your maybe slightly longer question, which was to Matt, which was, how did the groups discover the toolkit in the first place?
Really through the Alzheimer's Society networks. You know, that we had some good partners through the Alzheimer's Society, and also through the Association of Dementia Studies at Worcester. Not really, you know, it wasn't an area that we were well networked in, so we relied on others to spread the word, and then of course word of mouth, and that continues. I think it's hard to gauge how big their community is, but they do talk to each other quite a lot. So hopefully we're making the right impact and reaching the right people.
Yeah, sort of leveraging your existing contacts. Yeah, that's great. Thank you. Camille, your second question, which is tying together Anna's and Lindsay's talks, does true co-production with clinicians ever feature in designing services? Often the power is with policymakers rather than clinicians, and I can find that clinicians are treated as a uniform group rather than using personas like we do in co-production. It's a really good question. Thank you.
I can do you need to go ahead, Lisa?
You go. Yeah, you go, Anna.
So it's a really good question, and I think that's again about this communication that needs to be worked out, really. And honestly, I think in the UK we have really good examples of pilot studies where this communication did happen. And I think in the department, I'm just thinking about a handful of projects that were born in an academic setting, and they were trialed at St. Mary's or wherever, and they were able to scale up. So I would say that yes, healthcare professionals are sometimes involved in the process, and patients are more and more involved in the process. And I tend to be an optimistic. I think it's going to improve. I understand your question, Diogo, and I think, of course, there's a lot of things that we can improve there. But I don't think we should give up, and I think it's going to improve in the future. And also because there's this growing awareness, not only from healthcare professionals, but also from patients. They want to be involved. They want to know what's the process, and they want to have their voice heard. So this awareness is also growing, and this is going to push the political drive as well. At least that's my hope.
Thank you, Anna. Lindsay, did you have anything to add to that, or are we happy to move on?
Just adding to it in the fact that, again, it's so much important, as much as it is with the young people, but it is with the clinicians, the psychiatrists, psychologists from the start of a research project that is going to lead to change in policy and practice, to really invest in that time to develop that relationship with the clinicians and the young people and the researchers from the start, and then that would lead to much more sort of a co-produced approach that is acceptable to all.
So it's, you know, true equality from the start. Yeah, thank you, Lindsay. We have had quite a few questions, but we're not going to get through them all, but I will, you know, go down the list as they came in. We've had a couple from Diogo. I don't know if we'll have time to address them both, but maybe if we go with the first question, which was directed at Anna. Was there any assessment in terms of the cybersecurity of the solutions that were being delivered? It would be interesting to understand that in light of the array of cyber attacks that we've heard about taking place.
Yeah, so that's a very good question. So we didn't look at this in this specific piece, but we have a second paper in which we look at different policies implemented in a range of countries, and there's some really interesting findings. For instance, before COVID, there were actually really strict standards about the type of technology that we use to establish a connection with the patient. And what we have seen, for instance, here in the UK, but also in Australia and the US, is that the national healthcare systems actually stepped in saying, as I said before, use FaceTime, use WhatsApp, use whatever you have at hand that your patient is able to use. So definitely we loosened a bit our standards in what concerns cybersecurity, for instance, for digital remote care. And to be fair, we have loosened a lot of other standards in the context of a pandemic where the risk-benefit ratios do shuffle a little bit. So there are different responses. We don't know exactly what was the impact or what will be the impact in the long term. And this is certainly something that would be interesting to study, really.
And just to round that point off, in that if you're interested in finding more about this subject, the Institute of Global Health Innovation has been involved in developing a cybersecurity framework recently, which was published with the World Innovation Summit for Health. So please do go and have a peek at that document. In the interest of time, I think we'll just have one more question, which has come through from Palab, and I think this is a really good question. They've asked, I'm wondering what could be the possible ways to take these digital solutions to low resource settings. What are some of the bare essentials in some of these connected solutions that could be applied to low resource settings? I am based in the George Institute in India and working with large cohorts in rural and urban slum communities, both adolescents and adults, which is a major concern. So thank you for that question.
Who are you directing it to?
Anybody who would like to go first?
From my point of view in the Community Makers project, I guess we've drawn on we've latched onto the existing infrastructure of dementia support groups within the UK and the way that works. I don't think there's anything in the technology that couldn't translate into other countries or other cultures. We're not using high tech. We're using in some ways, it's all about doing things on a very tight budget and making it accessible to people with basic devices and basic things. But what I would wonder is if the support is there to attach the technology to in different places, and we've only looked so far within the UK for that. And yeah, within the sort of connected home project. The aims to make it affordable, make it passive, deliver it over. I think 5G has some amazing potential for making things more accessible and available, and that will be happening in a fairly short time frame now. So I think it all has global potential if it's not ready to ship out today.
Thank you. And Lindsay, I see you put your hand up.
Oh yeah, just wanted to add that obviously we're at the early stage of the research, but some of the main findings that came out are around peer support. Yes, digital peer support, but actually even face-to-face and things that can be translated into sort of more low resource settings, I think are actually quite applicable and quite transferable. Just basically maintaining that support even on a sort of a webinar sense, something just that everyone can then sort of access, I think is still going to be a possibility.
Thank you, Lindsay. Anna, I just suppose you had any final remarks before we wrap up?
I think, well, from the digital, at least from digital remote side, which is the area that I'm mostly focused on, I would say that actually low and middle income countries actually were in some areas they were a step ahead, because one of the advantages is that sometimes in low and middle income countries things were implemented from scratch in the first version that's already a bit better, while in high income countries we have been quick fixing our initial versions. So I would say that the potential is there, and there's actually a lot of literature showing that low and middle income countries actually did quite well in the adoption of digital first models. So I'm happy to share. If someone is interested, just drop me an email. There are really good examples from low and middle income countries, and things were not bumpy at all there.
Great, thank you, Anna. Yes, Camille has just popped over her details, so that would be fantastic if you two could connect afterwards. Thank you very much. I apologise that we are a couple of minutes overrunning, but it's been a really great discussion today. Thank you so much, everybody, for joining, and thank you very much for the speakers for talking all about how you've demonstrated that COVID won't stop your research, and how you're working towards better inclusivity and using technologies to better people's lives ultimately. So it's been really interesting to hear about this, and everybody please do keep an eye out for updates on these projects, because we will be sharing them in due course. And of course, a final thank you very much to Nikita for organising this event. It really has been fantastic. And that is it for our Global Health Forums for this term. So we look forward to welcoming you as they return in 2021. So do keep an eye out on our website, and also please do sign up to our mailing list if you'd like to keep up to date with our activities and events. So thank you very much, everybody. And thank you again to the speakers. We hope you all enjoy the rest of your day. Thank you very much, everyone. Take care.
Thank you. Bye-bye.